All right, it's 1 o'clock, so let's get started. Good afternoon, everyone. I'm Kyra Mann, CEO of MitoAction, and we thank you all for joining us for today's special Q&A with Dr. Jerry Vockley. I know these are really trying times for everybody, especially for the Mito, FAOD, and rare disease communities. So we want to ensure that MitoAction is here to continue to support you in any way you need us and for us to help you navigate these challenging times. Today's presentation will be recorded and available on the MitoAction website in the coming days. So please feel free to go back and check so you can re-listen and share with others who weren't able to be here with us today. We encourage you to ask questions throughout the presentation using the Q&A feature on the bottom of your screen on the menu bar. If you're calling in via phone, feel free to submit your questions via email to info@mitoaction.org. It'll be an open forum, and so Dr. Vockley will be taking your questions live, so we encourage you to, to participate and answer and ask questions throughout the presentation. So we are honored to have with us today Dr. Jerry Vockley, who is internationally recognized as a leader in the field of inborn errors and metabolic and fatty acid oxidation disorders. So welcome, Dr. Vockley.
Thank you. Shall we get started?
Let's go.
Okay. Well, I thought I would start with a few general comments. I know there will be lots of fairly specific questions, but I wanted to address some general ones first, and then we'll take some individual questions. Do remember that I can't answer specific questions about you or your child and their condition specifically. Those questions need to go back to your home physicians. I will, however, do the best I can to place the COVID-19 information that's available in the context of metabolic disease in general, fatty acid oxidation, and organic acidemias specifically. And most of this will also pertain to any of the energy disorders, including respiratory chain deficiencies, also represented by MitoAction. So excuse me, this is not COVID-19. I have allergies, so I promise I won't fall over in the middle of all this. COVID-19 is a viral infection, and you all know that in the context of metabolic disease, stress is something that makes your disorder worse. It can precipitate acute symptoms, and they can happen suddenly. Influenza, one of the worst viral infections that we face on a routine basis, is often thought of as just a cold, just a virus when we talk to patients. And in fact, it's quite a serious infection, and it routinely leads to a lot of problems in our patients. Excuse me. Got some stuff to drink here. COVID-19 is a virus. It's hard to say whether it causes more or less metabolic stress than influenza. Most of the problems that lead to individuals dying from COVID-19 are related to the lung. So it seems to have some sort of predilection to causing pneumonia, and once that pneumonia sets in, excuse me, it becomes more difficult for an individual to recover. whether the stress on the body prior to the development of the lung issues is similar, worse, or less than influenza, we really don't have any way of knowing. Now that said, it is very fair to say that an individual with an inborn error of metabolism, an organic acidemia, fatty acid oxidation, or respiratory chain deficiency, is at increased risk for having major problems related to that infection, related to COVID-19, than the general population. That may or may not manifest itself as additional problems with the lung, but it certainly represents the kind of stress that is likely to tip an individual with one of these disorders over into a metabolic crisis. So in general, the things that you should do if you feel like you have a COVID-19 infection are the same that you would do with any infection. That is, make sure you continue to keep calories going in. The calories keep your body from becoming catabolic, from breaking down its components to generate energy, and allow you to use that energy that you're taking in the diet to fight infection, regardless of the cause of the infection. Keeping up on fluids, so that you don't get dehydrated, and keeping your fever under control using Tylenol or one of the non-steroidal anti-inflammatories. There was some talk about the possibility that ibuprofen might be, there might be some increased risk with using ibuprofen in the face of COVID-19. That really hasn't been shown in any good study, and it is safer for you to get your fever down. So if you're using ibuprofen for that, then you're going to be better off if your fever is down. Probably better to go ahead and start with Tylenol just to be safe, or safest. But if that's not working, you can still alternate it with ibuprofen or naproxen, as we usually tell you to do when you have a fever. The other main component in dealing with this pandemic, with this infection, are all of the things that you're hearing from the CDC and other and media outlets about preventing yourself from getting it. Personal distancing, keeping yourself 6 feet away from anybody who's outside when you are, isolating yourself as much as possible. Keep your trips to the store to a bare minimum. And if you have one of these conditions, find somebody who can run your errands for you. Just stay home if you can. If you have to go out, wear a mask. There's been a lot of controversy about whether or not a mask protects you. The cloth masks that are being advocated now because of a shortage or an inability to provide everybody with a medical quality procedure mask is not likely to prevent you from getting the disease, but it does help you from spreading it if you're already infected. And if even if it has a little bit of an effect, it's helpful. Please do leave the medical grade equipment for healthcare providers, first responders, anybody involved in taking care of patients with COVID-19. It's critical for them to be able to protect themselves so they can help you, and they don't have any way of staying away from this infection. They're in the front lines. They have to be there. Self-isolating, mask if you have to go out, and keep a safe distance from you and anybody who is around you. I guess I'll dive into the chloroquine issue, because that's one I'm sure a lot of people are going to be asking about. First of all, when you hear that this drug has not been tested in the context of treating COVID-19, that is true. There's been one very, very small, very poorly designed study, almost anecdotal, meaning completely uncontrolled, where the conclusion was it looked like it might have made a difference. There are two other similarly poor studies that have said, no, we don't think it does. It has been used, looked at in the context of many other viral infections because of its proposed mechanism of action, including influenza, and it's not been shown to be effective in any of those. So it's possible it might help against COVID-19, but at this point, that's it. And the idea that the proposition that because it hasn't been shown to hurt, it's safe is just too dangerous for you. This drug does have some adverse effects that are particularly worrisome for fatty acid oxidation disorders. It can cause what's called prolonged QT syndrome. It's an arrhythmia of the heart that is frequent in long-chain fatty acid oxidation disorders and is sometimes thought to be a cause of sudden death when we can't identify any other cause in long-chain fatty acid oxidation patients who die suddenly and unexpectedly. It may make a cardiomyopathy worse. It at least, the tendency for the long QT syndrome to develop is worse if you have underlying cardiac disease, including cardiomyopathy. So you just don't want to use that drug unless there's clear indication that it's effective. There's also information out that suggests it might cause retinal problems, retinopathy. For those of you who have LCHAD deficiency or TFP deficiency or any of the respiratory chain deficiencies, you're already at risk to have retinal disease. And so this is a risk that I don't recommend you take. Unless there is clear evidence that it's going to help you, you should assume that it's going to hurt you, and just stay away from it. I think I'll go ahead and open it up to questions now and just deal with other things as they come along. So, Kyra, are you going to read those to me, or are you going to send me something by text?
Yeah, I'm going to read them for you.
Perfect.
So we'll go ahead and get started. What are some of the symptoms that we should be looking out for and should cause concern when we consider that a family member or loved one that might be infected with COVID-19?
It can be very difficult to differentiate COVID-19 from a standard upper respiratory infection, a cold, in the early going. Sore throat and dry cough are the two things that are oftentimes seen first, at least in adults. And when I say a dry cough, I mean one that doesn't sound like you're clearing your throat, unlike what I'm doing here with this with these allergies. A fever is very commonly a part of that. And there's a very interesting finding, which is a loss of sense of smell or taste. If you have any of those symptoms and suddenly your dinner just tastes flat to you, or you really can't smell it at all, that's an indication that you should potentially get yourself tested. Children can have similar symptoms, but can often be less specific. So you might see a cold, you might see a cough. They can have some GI symptoms, a little bit of nausea and vomiting, or even some diarrhea. So very difficult to differentiate from other viruses. If you haven't been exposed, that you know of, it doesn't mean you haven't been exposed, because there's still some debate as to how frequently individuals can be infected, and be infectious with COVID-19, but it might be as high as 50%. So unless you literally haven't been out of the house and exposed to anybody else, you have to assume the possibility that you could have been exposed. If you have any of those symptoms, the best thing to do is call your doctor, let them know what's going on. You do not want to run to the doctor's office, and you don't want to run to the emergency room, because you're almost certainly going to get exposed to the virus if you haven't already in those settings. So do the things that I mentioned previously: calories, fluids, fever control, rest as much as you can, and only if those measures aren't controlling your symptoms, then you should go to the emergency room, or call your local your PCP or your local metabolic doc.
Okay. So along those lines, as we know, there are often opportunities where outside of the COVID-19, it's necessary to go to the hospital for symptoms or things that are going on. Considering the potential danger of exposure in going to the hospital, what are your thoughts about deciding when you should and should not go to the ER? Well,
clearly, if you have an emergency, you have to go to the emergency room or seek care. If you're a fatty acid oxidation patient and you're having an episode of rhabdomyolysis, excuse me, speak to your local metabolic doc, and you might need to come to the hospital. You might ask them, can you have me bypass the emergency room and admit me directly? You can avoid the biggest risk there, or at least have them take you right out of the emergency waiting room, and into a safer space. If you're in an accident, if you think you got a broken bone, you got to get to the emergency room or an urgent care center to have that evaluated. So I think this falls into the category, you just have to use common sense, and if it's something that has potentially an adverse outcome for you if you don't go to the hospital, then you got to go to the hospital regardless of COVID-19. Take your mask, and I suspect that when you walk into an emergency room, someone's probably going to hand you one anyway. But take your mask and a personal distance, 6 feet away from anybody else in the waiting room as you check in.
Perfect. Okay. The next question. I have 2 children with MCAD. While I know children aren't normally hit hard with COVID-19, if they were to get it, are nebulizers safe to use at home?
Let's talk a little bit about kids and COVID-19, and for that matter, age in general. There's a lot of talk in the media about how older individuals, and that really is defined as 60 and above. 60 is not old. Are at increased risk for the more severe side effects or problems with COVID-19, and that's true. But anybody can be affected, and anybody can have one of the more severe presentations. Probably over half of the individuals who are hospitalized are under the age of 60. So it happens. Children probably right now are recognized to be only somewhere between 5 and 10% of identified patients with COVID-19 infections. However, that doesn't mean they don't have it. They're more likely to be asymptomatic, and at least thus far, it does seem like they're at lower risk of having one of the more severe manifestations. Your question relative to inhaler makes me assume that your kids have a problem with reactive airway disease, and so you have an inhaler around in case they have an asthmatic attack. If they are showing respiratory symptoms, if they're having this kind of allergic cough, or their wheeze, and it's a situation where you would otherwise use their inhaler, absolutely use their inhaler. Guidance right now is that inhalers are safer than nebulizers. So if your kids can use either one, opt for the inhaler because there's less dispersion of droplets into the atmosphere, into the environment, than with a nebulizer. But if you have to use a nebulizer, put your mask on and just go ahead and use it. I should also probably address the question of do we know of anybody with any of our diseases that have had COVID-19? The answer is a little difficult. My answer is no. I don't know of anybody that has it, but that's because they haven't been reported. There are some, I've seen some comments coming from metabolic centers in Italy and Spain that have said, yes, our patients are getting it, and we just treat them like any other viral infection. But I don't have any specific data on that. But if you look at the relative frequency of these disorders, so far there have been 350,000 reported COVID-19 cases in the United States. Some of those have to have some of these disorders, just by definition, unless our conditions protect us, which they certainly shouldn't. So there are likely patients with metabolic disease who are in that number of affected patients. Probably some even in the category of patients who have died, and we just won't know about it until all the statistics are accumulated, probably months or years from now.
Yeah, thank you for that. The next question is, if you are a carrier of COVID-19, will you have antibodies? And the second part is, at some point, should we have our kids tested for antibodies when the testing is more available? Any viral infection generates antibodies. That's how we become immune to infections. That's how we get vaccinations. The body generates an antibody response. The type of that antibody response determines how strong the resistance is, the immunity is to the disease in the future, and whether or not you are immediately protected from it. There are a number of different kinds of antibodies, and they all have letter names. So there's IgG. That's the one that everybody sort of thinks about as when you have an immunity to a previous infection. You've got IgG floating around in your body that can glom onto whatever it is that's attacking you and take care of it before it has a chance to come back and get you again. However, IgM is the first antibody that is mounted in an immune response, and while that will help clear an immediate infection, it doesn't say that you're immune long term. Most of the time, the IgM precedes IgG development, and most of the time, if you've got an IgM, you will develop IgG eventually.
but you need to know what the type of antibody that you have is. There's one other type of antibody, IgA, and that gets down into gets excreted out into your lungs, and can protect you even before something gets into your bloodstream. So everybody will develop an antibody response unless you have a genetic deficiency in that. In the short term, it probably doesn't help you to know that you have that antibody unless they're telling you specifically that it's IgM or IgG. Long term, it may help you depending on the life of this virus. There will certainly be large studies out there, and we hope that we'll be conducting one of them to see how many people got this disease, how many of them knew they had it, and therefore how many of them were asymptomatic, and now how many of them are immune. Very helpful if you're a healthcare provider, for example, and now you're in the emergency room and you know at least that you don't have to worry about being infected with this same agent. Probably not worth your while to have that test done unless we see another round of infection. There's some thought that once the first pass is over, until we get an immunization to it, there may be some additional rounds of infection, in which case, if the test is readily available and you can have it done, you probably would want to have it done so you know whether or not you're at risk.
Okay, there we go. Thank you so much for that. My 3-year-old son has VCLAD and hyperthyroidism, and it looks like it is going to be admitted to the hospital. How can I protect him from getting ill while in the hospital?
You have to trust your hospital. Your hospital should be, you didn't say why your child was going into the hospital, but if it's because of an episode of metabolic decompensation, they should be putting him or her in a room that is not exposed to infectious patients. Right now, hospitals are trying to cohort them into separate parts of the hospital. That may or may not be completely possible. But then everybody should be taking precautions who's caring for your child. Here at Children's Hospital Pittsburgh, we've got a lot of things in place. First of all, everybody who's in the hospital has to wear a mask. If you're going in to see a patient, we wear the mask. We are limiting the number of people who see a patient. That endless stream of people who come in to see your child when admitted. First there's the intern, then there's the resident, then there's the fellow, then there's the general attending, then there's the metabolic fellow, then there's the metabolic attending, and all you want to do is go to sleep, right? Well, that's not happening now. We're sending one person into the room. They're responsible for telling everybody else what's going on, and that limits the exposure to somebody who has no known viral exposures. And then finally, the COVID-19 patients should really be very, very well isolated, cohorted away from the other patients in the hospital. So I can tell you, for example, that as of the start of this webinar, there were no COVID-19 patients in Children's Hospital. So far, it hasn't hit us. we also haven't had any of our staff affected, and so you're actually probably safer in children's here than you are out in the street where there are people walking around who have the infection. That's not going to last, so you don't want to be in the hospital if you don't have to. But if those kinds of, and I did mention hand washing, in and out of the room, everybody should be hand washing. And I think I didn't say that in my general comments as one of the effective ways, just constantly washing hands. So those are the things that will keep your son or daughter safe in the hospital.
Okay, great. This one might be a little bit too specific, but we're going to give it a go. Is 1.5 times maintenance DT still okay on the heart and lungs if COVID-19 is causing inflammation in the lungs, and what are the risks of fluid overload?
Yeah, that's a pretty specific question. I'll try to be general and hopefully give you some information. But this is going to be the kind of thing that your metabolic physicians are going to be standing there working on with your intensivists. You mentioned D10 1.5 times normal maintenance. Many of you will recognize that as our secret sauce, our magic recipe. If you come into the hospital, we give you that. The reason we give you that is that gives you an amount of glucose that we know is sufficient to start shutting down catabolism and negative energy balance and turning it back into positive energy balance. So when we don't have anything else that we can do, that's what we do. And so that will likely still be the first line of treatment if you happen to be admitted for COVID-19. You're right to worry that in the context of lung inflammation caused by pneumonia, caused by the virus, that you can have fluid leakage into the lung, and so that will have to be watched very carefully, and your intensive care team and your metabolic doctors will know to do that.
Okay, great. Thank you so much. Hospitals near me have stopped admitting peds. If I need to take my son to the hospital, should I go to the local ER and then be transferred, or should I take the time to drive to the next closest hospital so that we are only in one ER?
Depends on how far you have to drive, and I'm sorry to sort of dodge that question on you, but it is certainly safer to only be in one emergency room, but how sick you are or your son or daughter is really going to determine whether it's safe for you to take that extra time to drive to your local metabolic center. Ideally, that's the place we'd like you, or the next closest hospital that's taking pediatric patients if it takes you too long to get to the local hospital. If you are thinking you need to go to the emergency room, please call your PCP or your metabolic team or both and get their guidance as to what the best course of action is. We can usually tell by talking to you what we think the relative risk is, and so your docs can give you a better idea of whether you should go to the local ER and get yourself transferred versus trying to get to a distant one.
Okay, great. Thank you. The next question is, I know people that have been turned away from getting tested for COVID-19 because they do not have enough symptoms. Do people with underlying health conditions like FAODs get priority for testing? And if so, does a patient need to provide proof of their condition?
You're right, there are not enough tests nationally yet. Thus far, the answer here has been having an underlying condition has not been enough to get you a test, because the the question that you have to ask is that test going to change your acute management? It certainly will affect whether or not you have to, how long you have to be isolated, how long you have to be in quarantine. But the initial therapy is going to be the same regardless. It's those steps that I mentioned earlier to try to keep yourself from becoming, getting into a metabolic crisis. And it would only be if you got into a metabolic crisis, ended up going to an emergency room, or even admitted directly to a hospital, my preference, if you had any symptoms that were suggestive of a viral illness, would you likely end up getting a COVID test? That could change very much over the next few days, and unfortunately, much of what I'm saying is very, very time dependent, and so definitely keep an eye on the news and talk to your docs if you feel like you have some reason to be concerned. But there's still a suggestion that more tests will be made available in the coming days and weeks, and so if you feel like you need one, call your care provider and ask, and they'll tell you what the local availability of one is.
Great, thank you. The next question: is it recommended to stay away from the hospital if you have to go there for IV treatments for other disorders? And this particular patient has POTS and MCAD.
So I assume you're asking about IV fluid for your blood pressure, given that you mentioned the POTS. All I can say is having a blood pressure that's too low is also not good for you. And if you can't get it up by using any of the other means that you usually use, presumably some pressure medication and oral fluids, and you need IV fluids, and you're not set up to get them at home, so a lot of qualifications there, then you have no choice but to go to the hospital.
Okay, great, thank you. We're in Canada and my daughter has Allergies. It looks as though our chief medical officer is conducting a study for a malaria drug to treat COVID-19. Is this the same drug you were speaking about?
Yes, that's probably the same one. I don't know about the Canadian study in particular, but I assume that's it.
Okay, great, thank you. I have my son tucked away in the house for the past 3 weeks with an occasional car ride. Is there anything else I should be doing to keep him safe?
Yeah, keep yourself safe. Being in quarantine with a partner or kids or anybody without being able to get out is tough. Do give yourself a chance to have a sanity break, some way, shape, or form. Beyond that, the answer is no. Even in the house, making sure you're washing your hands fairly frequently, and keeping some distance when at all possible is reasonable. But there's not much else you can do as long as you're not going out and getting yourself exposed as well. So you stay safe, your child stays safe.
Perfect, thank you. I've heard that if this gets worse and there is a lack of equipment, that they will choose healthier individuals, and that FAOD children individuals would be on the list for those to be excluded for immediate care since they have a metabolic condition. Is there truth to this?
No discussion of that. And in fact, I think it would go the other way around. At least in a pediatric center, everybody who comes into a pediatric center is a patient who has decades of long life ahead of them, by definition, if you can keep them healthy. We're all trained to take care of chronic disease, and we would never let the presence of a chronic disease influence our use of otherwise life-saving interventions. Remember, we don't have any reason to think at this point that because of these diseases, you are at an increased risk to have a problem with your lungs. That's what's killing people. It's the lungs. And so you will be cared for in the same way as anybody else, it may well even be that you have priority because you have other risks that can be ameliorated by bringing you to the hospital and treating you more aggressively, rather than saying, why don't you tough it out at home and see if we can get through this.
Okay, great, thank you. What do you think about taking your child out to the park to get exercise in early morning hours before people are outside, especially for people who have no green space?
Yeah, at this point, most stay-at-home recommendations are including an exception to go out and get personal exercise in a setting that allows you to keep your distance. So if you could stay 6 feet away from anybody else, then absolutely feel free to go out. The outdoors are going to be safer than indoors, so don't make that exercise a grocery shopping trip. Make it a walk around the block. Stay away from any congregating kids. You know, if they're kids don't pay attention sometimes, and they might be down the street shooting basketball. Stay away from them. Go around the corner. And as long as you're staying away from others, the exercise and the sanity of getting out will be good for you.
Yeah, great. Thank you for that. Any additional complications foreseen for patients who also have liver transplants?
We do have some private communications from our colleagues in Italy who have taken care of patients with liver transplants, and they have not seen anything in those patients that hasn't been seen in anyone else. The immunosuppression that is used chronically in patients with liver transplant is not doesn't affect the response against respiratory viruses very much. So I can't say there's no increased risk of getting infected, but it doesn't seem like there's a big increased risk that you face over everyone else. Keep in mind it's very, very limited data, and I'll just keep coming back to saying the best thing you can do is stay safe, stay home, wash your hands, personal distancing and self-isolation to minimize whatever risk that you face.
Perfect. The next question: when we go for walks or bike rides around the neighborhood, should we still wear masks? We do stay away from the neighbors.
I would. I think this is a situation where it's better safe than sorry. This is droplet spread. 6 feet is a fairly safe distance. But if somebody sneezes 6 feet in front of you and you walk into it, it's no longer 6 feet. So I would wear the mask.
Thank you. The next question is, are kids with FAODs at higher risk given underlying risk of cardiomyopathy?
So far, I haven't heard or seen anything in the medical reports about cardiomyopathy. There's some suggestion that if you have underlying cardiac disease, that the lung disease is likely to, it's a stress on the heart. But there's nothing about the cardiomyopathy or fatty acid oxidation that we know about that should make the lung disease any worse. I do worry that if you have a cardiomyopathy and you undergo any metabolic stress, COVID-19 or otherwise, that your cardiomyopathy could get worse. So your physicians certainly should do a good physical exam looking for signs of worsening cardiomyopathy. Doesn't mean you have to have an echo, but maybe an EKG and certainly a good exam where a physician's able to listen to your chest for signs of cardiac failure.
Okay, great. Next question. Are there additional measures we can take to manage a crisis at home to avoid a trip to the hospital? And the example that they cite is assembling Gatorade with MCT oil to help with hydration issues.
All of the things that you usually do when you're sick at home are the things that you should do if you're worried about a COVID-19 infection or something else and you want to stay away from the hospital. Calories, depending on your condition, that's going to be different. So the MCT works for long-chain fatty acid oxidation defects and the organic acidemias and the respiratory chain defects, but not for MCAD. So calories, including Pedialyte with extra sugar, MCT if it's appropriate for you, your metabolic formula if you're on one, and just eating a regular diet. We usually, we usually tell our patients to increase their calorie intake by a quarter or a third if they're under metabolic stress. In other words, if they have an illness. So it's a rule of thumb you can shoot for.
Great. So here's a lighter question. Any suggestions on ways to get a 3-year-old to wear a mask?
I can't get some of my faculty to wear a mask, let alone 3-year-olds. No. You just got to keep it on. Eventually, excuse me, it's pretty amazing. I'd put on a mask if I weren't talking to my screen right now. It's amazing what kids will get used to, and while they'll turn it off, take it off eventually, usually eventually they'll leave it on. The kind that are easier, I don't have one handy here to show you. They have, instead of the tie-on ones, they have a little elastic loop that fits behind your ear. Those are harder for them to get off.
Okay, great, thank you. I'm sure that's something a lot of parents are struggling with right now. Another question is, once this is all said and done, and the stay-at-home orders are released, what are your thoughts about what will be the necessity for patients with FAOD to continue to wear masks out in public and to continue to maintain levels of caution since there are so many unknowns about COVID-19?
I would say that everybody, not just patients with metabolic disease, but everybody really ought to be looking at a cautious reintegration once things are lifted. I would assume that schools are not going to go back into session for kids. You're going to be dealing with neighborhood exposures rather than school exposures. It's a little bit easier to handle with kids. But if you're going back to a job and you have a fatty acid oxidation disorder, you should at least work on maintaining that personal distance until it's clear that everything is resolved. Whether you want to wear a mask for that period of time or how long you feel comfortable before going out without a mask, I think is probably, I can't give you good scientific data on that. I think it's going to be personal. personal preference. I think you just have more of the issue is going to be how quickly it's lifted. So if the restrictions are lifted prematurely, then absolutely you follow precautions. If there's good agreement and you're not hearing people yell at each other across the news channels, then it's probably safe and you don't have to worry too much about it.
Okay, great, thank you. Would handkerchiefs be as effective as masks, since you can still contract the virus but would keep others safe if you have?
Well, anything is better than nothing. I've seen people are tying kerchiefs, they're tying rolled up T-shirts, they're doing all sorts of things. I've seen patterns on email feeds for masks. I know of groups that are sewing masks to be distributed to healthcare providers. So whatever you can do is what you can do. I guess I wouldn't go as far as saying a cloth mask or a kerchief isn't going to be completely useless. It's just not going to be the same as a surgical grade procedure mask. So if it's what you've got, use it. I think if you Google a COVID-19 face mask pattern, you'll find something in an instant. And if you're not so talented to make one, I'm sure you could find someone who will help you out.
Perfect, thank you. So I have one last question before we wrap up. And that question is, hang on one second here. I'm from Mexico, and for some reason, we have much less COVID-19 than in the US. Are there any studies showing any differences due to cultural differences or ethnicities, and why some people are getting it and not?
Not right now. There are certainly going to be some factors that are identified down the road that are protective against this virus. There are lots of examples of those sorts of factors. They tend to be very minor effects, however, and they're only obvious when you look at them across a large population. It is true that we have fewer reports of COVID from Mexico than we do from many countries. But then, we also have fewer reports of COVID in some parts of US than in others. So it's hard to know if it's exposure, if it's climate, if it's something else in the environment, or if it's some intrinsic factor that ultimately will show us the way to coming up with medications or preventative immunizations to prevent the disease.
Okay, great. And then I'll give you one last question. So for a lot of patients in the rare disease community, this is their normal, right? Protecting from infection, staying inside during flu season. What are your recommendations for families to help others understand how serious this is? Because unfortunately, there still are a lot of people who aren't taking this seriously. So what is your recommendation to help communicate that?
Well, I think any time any chance you have to advocate for that position, you should certainly do it. I do think that there are a lot of people out there who are really probably for the first time stopping to think about what it means that being exposed to somebody else could make you sick or kill you. In the rare disease community, in the metabolic community, we live with that. You're right, and we worry about it constantly, and I think that a lot of individuals, the vast majority of folks, by all reports, are following the lockdown recommendations. Yes, there are always going to be disbelievers who say, you can't convince me that I'm at any risk, and therefore I'm just going to go out and do what I want to, even though they're putting you at risk. Stay away from them. and be glad that most of the people around you are listening to the recommendations. But any chance you have to advocate for the attention that these diseases deserve, you certainly should take it.
Absolutely. Thank you so much. So Dr. Vockley, I just want to give you one last opportunity to share any last thoughts or anything, suggestions that you'd like to share with the community before we wrap up.
I very much like the last comment, which is to say we've been through this before. The rare disease community, the metabolic community has been through this before, all the time. Any infection out there is serious for us. And so while this is fundamentally different from for the rest of society, you have at least a little bit of a leg up in dealing with it from a personal, from a family, from a psychological standpoint, that I hope gives you the resiliency that you need to get through this in a way that may be difficult for others who've never had to face these issues before. My closing plea is to please stay safe. Use precautions, eat well, stay healthy, and stay in contact with your healthcare providers. If you do have any medical concerns, we will never turn you away from hospital care, but we'll try to make sure that you really need it before we bring you in and expose you to it.
Great. Thank you so much, Dr. Vockley. We are so appreciative of you taking your time today to share your expertise and to really ease the burden and the anxieties of the community. This was incredibly helpful. I know that everyone is sitting at home and may still have a lot of questions, so I would encourage you to, if you want to, still send those in to us at info@mitoaction.org, and we will continue to be here to help you and support you through this crazy, crazy time. Just so as a reminder, we are recording today's presentation and it will be posted on the MitoAction website for anyone who would like to listen again or share with others. We thank each and every one of you for joining us for today's presentation, and we want everyone to be safe and healthy. And if you need us, please don't hesitate to reach out. Thank you so much, Dr. Vockley.
Thanks to all, and please be safe. Bye-bye.
Wonderful day. Take care.